Hello everyone. This is a video Dr. Mooney is presenting for us for a regional hip block that we help for setup of the procedure as well as the patient assessment and assisting during the procedure. So here's Dr. Mooney.
Hi, so in this case, we're talking about a fascia iliaca block, which is a regional nerve block for our hip fracture patients. This is something that St. Peter's is promoting that we should all be doing. It shows that it controls patients' pain better, leads to less incidents of delirium. Ultimately, they get to the operating room faster and discharge from the hospital faster, which leads to better patient outcomes and higher patient satisfaction. So it's an important thing we should be doing for our patients. So we just need to go over how to set this up. So we need a couple things. First, we need the ultrasound machine, and then we need the kit. And I'll go through the details of the kit in a moment. Ultrasound machine should be set up on the opposite side of the fractured hip. So in this case, we're pretending it's the left hip that's fractured. So the machine is across the patient, so we can see the screen while I'm standing next to the patient. Once that's set up, we could take the kit out, and this is what we got here. Should be in a bag I think in the Pyxis or a closet somewhere.
In the Pyxis, yes.
So we have ChloraPrep wipes. We have two different syringes. This is for local, and this is for the regional nerve block. We have the nerve block needle. We'll go over that in a second. Drapes, sterile gloves the doc will need. Our medications, you really only need local, which is lidocaine, and then mostly ropivacaine. Doc might decide bupivacaine for another reason, but we should be doing ropivacaine, less toxicity, which we'll talk about at the end. Are just needles if we need them, and the ultrasound probe cover. So, thank you very much. All right, so the setup goes. In an ideal world, you have plenty of time to spend with your patient, and you can get this whole thing set up before the doc comes in the room. But obviously, I know that's not always going to be the case. But just so you understand the setup, so this, if you can get to that, we expose the patient's hip. In this case, we're just going to pretend it's exposed. The area around the inguinal crease should be sterilized. That's what the ChloraPrep is for. So you give a nice big sterile field there. Then we would do the drape. So we might want more drapes in the future as a part of this kit, because we kind of want to shield, everything besides the area in question. But in this case, we have one drape, so we'll just put it right there for now. And then the probe cover will go on. So
while Dr. Mooney's preparing that, just a reminder that we need to make sure we have a consent for the procedure, as well as the patient's on the cardiac monitor. We have a blood pressure cuff on and oximetry for monitoring, and we'll go over the post-procedure vital signs after.
Have you hold it up like that right now.
Okay, got it.
And
a timeout before he actually does the procedure. We should time out in the room.
And one other thing the doc should do before they get any of this stuff set up is to make sure they have a look at the anatomy and at the hip, an exposed hip, before they get started. There may be a lesion or a rash or something like that they're not going to be able to pass the needle through. So we should know that before we even get this far. So important to make sure the patients are undressed.
Right. Very good point. Everybody undress your patients.
So, pretending to be sterile here. So now you can turn that upside down, pass it right into there. There you go, and on there. There, so, all right, good. So then the way this works is, I push this through, you grab that, press to grab that plastic there, and then you pull that all the way down, and then that's it, all right. So, the doc will usually be in the room during this part of the procedure and be assisting in this as well. But if you're feeling really good and can keep it sterile, you can do it yourself and have it set up. That would be amazing. And a little jelly on the outside. So, all right. So the patient's ready. The patient's cleaned off. We've drawn up, hopefully, 10 cc's of local lidocaine. The doc uses the probe to find where they want to go. They identify where they're going to go through the skin. That's where the local lidocaine will go. And that goes down. And then Chris, I'm gonna have you come around this way. Once the local is in, we'll draw up the whole 30 cc vial of this thing. We're gonna push most of this 30 cc. Now, it is a weight-based dose, but the patient should get at least 30 cc's of volume. They may only want 20 cc's of the ropivacaine and 10 mLs of sterile saline, but they should get a large volume block, because we need to bathe a lot of area with medicine. So I'm gonna have you hold the medicine, pretend the doc will draw it up using one of these needles here. It's now drawn up, the whole 30 cc syringe. All right, now the doc then connects it to this tubing on the special regional anesthesia needle. We like this needle because it's very controllable without having to manage a big syringe. It shows up well on ultrasound. So Chris is gonna take down the syringe and hold that. And the way this will work, the doc will be here identifying the anatomy and go into the patient with the regional needle. When the doc says they want you to push some medicine, you push 3 to 5 mLs at a time. What we're doing is hydrodissecting, it's called. So basically, as the mLs get into and the liquid gets into the tissue, it starts separating some of the anatomy. It can clarify the picture, makes identifying the needle tip easier and making sure we're in the right spot. And the doc will probably have to do adjustments with the needle tip. So every time they do an adjustment, they may want you to push a little bit more of the ropivacaine in to help kind of separate that out. Ultimately, then the doc will find that we'll get into the right fascial plane with the needle, and at that point you just do slow 3 to 5 ml pushes at a time. You know, and the doc will kind of just tell you how they're doing. They should tell you how to do it. All right. You might just say, hey, or just push it all slowly, and the doc can adjust, but don't ever just slam it in.
Right.
All right. So at that point, the medicine's in. We'll put the syringe in it and the needle down. Just local, puncture wound care, like a Band-Aid in the area. The doc is now done at that point after they've cleaned up their sharps.
Okay.
And the doc will walk out of the room.
So for nursing, yes,
Right,
at this
go ahead.
point,
Yeah.
we're post-procedure, we're going to, patient's already on the cardiac monitor. So we need to monitor our vital signs every 5 minutes times 3, then every 15 minutes times 1 hour. And Dr. Mooney's going to indicate why we're monitoring these at least within the hour. We need direct supervision with the patient for the first 15 minutes after that block is completed. And if the patient's stable after the first 15, your direct one-to-one is no longer indicated. If there is any change in condition, and Dr. Mooney's going to explain that, a systemic reaction of some sort right now, you need to get the provider right away. So go ahead.
So the concern is for a condition called LAST, or local anesthetic systemic toxicity. Super rare, but can be very serious and dangerous. Now what you're looking for is anything that from very minor symptoms to metallic taste in the mouth, to tachycardia, to bradycardia, to hypotension, but also can involve seizures or cardiovascular or cardiac arrest. So we're thinking neurologic and cardiovascular symptoms. If they're going to occur, it's usually within the first 20 minutes. So if your patient complains of any of those symptoms, get the doc aware and then consider getting interlipid right away. So this is the interlipid. The doc will order this. If the patient needs it, we'll hang the interlipid. There's instruction sheets there with the kit.
How to administer, yep.
And it's in the Pyxis.
Right.
And this is the treatment for that LAST syndrome that we're talking about. And then the patient will need to be admitted to the ICU at that point if they need it. So.
Okay.
Okay.
Okay, great. So that concludes the video. Any questions, please let us know. Thank you, Dr. Mooney.